Okay, good evening and welcome to Rural Medicine Grand Rounds. I'm Dr. Stuart Glastonbury. Tonight's case is on androgen deficiency presentations in rural general practice. Discussing our case tonight, we have Professor Scott Kitchener, Clinical and Academic Lead, Rural Health, Griffith University, General Practitioner, Clifton Medical Centre, and Medical Director of Queensland Rural Medical Education. Next to me on my right, I have Professor Jeff Nicholson, Endocrinologist at Toowoomba Base Hospital and Head of the University of Queensland Rural Clinical School. Please welcome our specialist and expert panellists. As usual, we're being live streamed around Australia. You can join this discussion by emailing your question to media@qrme.org.au or you can use the hashtag on your screen. Our presenter tonight is Dr. Sidya Raghavan from the Range Medical Centre Toowoomba, and her presentation will be on androgen deficiency. Please put your hands together for Sidya.
Thank you very much, and a very big good evening to everybody here and watching live as well. So as Stuart just said, today's case is on androgen deficiency, its diagnosis and management in rural general practice. So this is Mr. X, who presented with his wife as a new patient, and he was a 35-year-old male with an occupation as a farmer. His presenting complaint was that of weight gain, which was then leading on to a bit of low mood and social withdrawal. Towards the end of the consultation, as most men do, he said, oh, he's been having troubles with difficulty in bed as well. So we had a bit more discussion as to what exactly does he mean by that, and his symptoms were that he had troubles having early morning erections, and if he did have one, they never lasted to actually have any action happening. And from speaking to him, it looked like that was a big concern to him, and the presentation completely changed to being more about difficulty in bed for us. So continuing with the history, he had no significant past medical history. Family history-wise, he had a father who had diabetes and bowel cancer, both under control. He didn't have any regular medications, had allergy to morphine with a rash, and personal history-wise, he's a non-smoker, very occasional use of alcohol. On examination, he was quite a tall, hefty bloke with a BMI of 46.5. His vitals were quite normal. His systemic examination was very normal as well. On mental health assessment, he seemed to have a bit of mild to moderate sort of a depression, which seemed to be stemming more so from his weight gain and a bit of the difficulty in bed as well. So I guess at this stage, what most GPs and people like me who are registrars think about is it just a depression case? Is this just a depression who's presenting with erectile dysfunction? Do we just treat the depression, treat his weight, and hope that his erectile dysfunction gets better? Especially given that he is only 35 years old. Or would you take a tangent and think, oh, well, you know, that's a bit unusual. Can we do something more for him? Do I investigate further? Do I do any referrals over here? So in this instant, what I did was I thought he does need a screen for his depression, certainly. And being very young, I thought I would definitely do a testosterone as well in this case. So when we did the investigations, his full blood count, kidney, liver functions, thyroid, and lipids came back completely normal. The lipids I purely did because he had erectile dysfunction and he was morbidly obese as well and has a family history with father having diabetes. So I was just trying to rule out all of the cardiovascular risk factors as well. Luckily for him, everything was normal as far as that goes, but his testosterone was extremely low at a 4.8. I guess the next question is, what do you do? Do I still think it's just a depression and his testosterone is very low, probably because he's very obese? Do I maybe treat his obesity and depression and hope that I do one more in 3 months' time and maybe it'll be better? And at that stage, if it's still very low, maybe think about some sort of a treatment for it. is what I was looking at. And I must say, when I spoke to 3 of my colleagues, each one of them gave me a completely different answer. So because it was a low testosterone and it was that low, and he was only 35, I really didn't expect that low level for him. I went ahead to do more investigations. Now, these are the conditions which are where you see low testosterone. How often do we go through them and actually say, okay, I don't think it's this one, maybe not this one, maybe this one, you know? We rarely ever do that. I guess one, we are time constraint is a big thing, but quite often we just think erectile dysfunction just needed to treat with a cardiovascular side profile, making sure we have done that, and then treat him maybe with testosterone or with PDE5s, basically. So I went ahead and did more tests, and as you can see on that, his FSH, LH, and cortisol were quite normal, but his prolactin levels were really high, very high. And we then did a CT, which confirmed a pituitary adenoma over there. So I guess at that stage, if we had just thought he's a patient with depression and he's just having erectile dysfunction as a part of his depression, we've completely missed the boat over there and we've gone in a different tangent. Now this guy, we did pick him up and he was then further referred to the endocrinology unit in Toowoomba Base Hospital, and he was seen by Professor Nicholson. Since being started on cabergoline, and his prolactin levels are coming down. One thing I didn't mention in that was his testosterone levels, though, haven't come up yet. So in summary, this is a 35-year-old male, main symptom of erectile dysfunction, examination being normal, investigation showing a very low testosterone. Further to that, doing a prolactin level, which showed very high levels, and then we did a CT confirming his pituitary adenoma, and has been treated for this at the moment, and still undergoing treatment, actually.
Excellent. Thank you, Sidya.
Thank you.
Okay, so I guess it's a really interesting case, and also a really young man as well. I guess one of the questions that I was sort of thinking too was, with such a young man at 35 years of age, which I guess androgen deficiency would be an unusual presentation for such a young man. Do you see this age group?
Well, certainly in my clinical area, because obviously they get referred to us. But I think that's something you need to be thinking of, from the time of puberty. So it might begin with delayed pubertal development, and I've certainly seen patients with prolactinoma, and that's the problem. Delayed growth, for example, right through to old age, so they can present at any age. Just some comments on the endocrinology is a clinical disease, and one usually makes the diagnosis from the history and examination, and the tests come a long way second. So I'd be very curious about, you said his examination was normal, but was it normal? And there are a bunch of questions that could be asked about his testosterone function from a hormone point of view. And there's some quite simple things like shaving. Is he still shaving? How often? And other gynecomastia, did he have any breast tenderness or enlargement? His morbid obesity, any change in the shape towards a more feminine shape and loss of muscle, and so on and so on. So there's a clinical syndrome of hypogonadism in an adult male that should be fairly easy to recognise, more than just difficulty in bed. Do you want me to keep talking about this? Yeah,
that's good. Thank you.
So, and I guess the same with the test. Now, I wonder how many people here would do a serum testosterone. A serum thyroxine as a screening test. Well, you wouldn't, would you? You'd do a TSH, right? Which, in this case, this is a good example where the regulation from Medicare is that your screen with a TSH can be quite misleading. So I didn't see his TSH. I don't know if you put it.
Normal.
Yeah, but what's normal?
Yeah.
So if you think you're going to do a testosterone based on clinical grounds, then you need to do the testosterone, the free testosterone, and the gonadotrophins, and I would always throw in the prolactin, right? Because the prolactinoma is one of the more common causes of this presentation. And it might be a microadenoma where the mass is quite small, not visible on CT scan, but the prolactin can be high enough to cause secondary hypogonadism. What was I saying? I lost the track there. Or there can be a mass effect. So even a null tumour that's causing a mass effect will raise the prolactin and lower the testosterone. So you've got two separate effects. The prolactin alone, raised, will cause hypogonadotrophic hypogonadism, and or a mass effect will cause a modest elevation of the prolactin and secondary hypogonadotrophic hypogonadism. So it's because a lot of testosterones are done and they're very hard to interpret. Now, it was easy in this case because it was so low that you did something about it, but you may have got one back that was just sort of in the grey zone, and then you might have thought, oh, well, it's his depression, that may well have been, and missed the prolactinoma. So I think if you're serious enough about doing a testosterone, measure the gonadotrophins and the prolactin.
We were talking a little bit about physical examination there then, and Sidya, I noticed that you said that you didn't examine the gonads. Was there a particular reason for that, or, you know?
Well, it was offered to the patient and he declined the offer.
Right. Okay.
Just as a part of your regular abdominal examination, I did that, but not specifically thinking that his testosterone is going to come back very low or anything like that.
So it's interesting, you talked with other GPs. So what were their thoughts on this case?
So most of them that just thought it would probably be a depression, and they would treat the depression and treat the weight gain as well, and retest it in 3 months' time. And if it still was low, then they would think about maybe starting some testosterone androgen replacement, basically. That was what most of them were thinking about. Yeah.
So Scott, you're working as a GP out at Clifton, and Clifton's a fairly rural location. I guess you probably see presentations like this quite commonly, yet I guess an older cohort demographics.
Yeah, I mean, there's a lot of rural medicine issues here, and it would be interesting to know what sort of. I would be interested in taking a history of the nature of his farming. The first thing to rule out is whether or not he's exposed to any chemicals, or particularly whether he's using anything on the farm that may be causing some of these issues. And it would be pretty unusual for people to be using animal-based hormones themselves, although it's not unknown, and you'd want to check that. And particularly in farming at the moment, it's a marginal economic pursuit at this time, and so the issues for this man in terms of his fatigue and his inability to, his weight gain, his inability to actually perform, may lead him down the wrong path. The other thing that I would also think about is hemochromatosis is actually very common in the pedigrees in rural areas, and you see quite a lot of poorly diagnosed hemochromatosis and or undiagnosed hemochromatosis. The other issues for this fellow are around image as well. You know, it's a very masculine industry, agricultural industries, and so for this man to have be overweight and be unable to do all of his duties on a farm, and then for that to flow into the bedroom is certainly going to exacerbate the depression. And I wouldn't be surprised if, in addition to dealing with the endocrine problems, you're also going to have to deal with depression anyway, and explore all the other issues that are going on in his life, because it would be unusual in an agricultural community for it just to be a testosterone deficiency from a prolactinoma. I think there are other issues that you'd want to explore. I think he was also very lucky to be able to come to you with such, and to Jeff to have those services readily available to him.
It was all done by the time I got to see him.
Well, but his access to these services is something that's very fortunate. Many farmers would have to travel much further to get access to a specialist endocrinologist. So I would count him as an unusual but very fortunate farmer. So I think there are a lot of rural medicine issues in this case that you've overcome very well.
Yeah. Just and hypogonadism in males is frequently underdiagnosed. So I see people who, and it's not just a rural issue, patients who have clearly been admitted to the Royal something in multiple capital cities and have conditions like Klinefelter syndrome. In other words, they've got primary hypogonadism, profoundly clinically hypogonadal, usually with gynecomastia, feminine body shape, testes the size of a pea, and micro penis, and they've never been examined. Or if they have, that hasn't been recognised. So part of the examination of any male is to have a look at the genitals. And I understand the reluctance, but it's something I think you have to sometimes persist with. And of course, the other thing in the male of this age would be what? Could have a tumour somewhere else. Tumour on the testis, right? That secrete hormones that can make patients hypogonadal. So we see patients who present with galactorrhea who have a beta-HCG secreting tumour and develop secondary hypogonadism from that. And there it would be really unforgivable not to examine the testes. Okay, so I would really urge you to, one, take a more thorough, I know it's a delicate issue, but take a very thorough sexual history and ask about things like change in body shape, loss of muscle tone, breast development. Did he have any gynecomastia underneath the 168 kilograms?
I don't think so, no.
That'd be surprising, really. Under a BMI of 46, you'd think you'd have some.
Yeah, but you might be able to feel it, and he may also have expressible galactorrhea. And so sometimes you have to do some strange things as an endocrinologist, like squeeze the breasts in males, and like sometimes, particularly if they're a farmer, they look at you a little bit strangely.
I think that's an important history with important aspect with a lot of male farmers is that obviously the diagnosis and management of this case requires a longitudinal approach, and so you're going to have to be with this fellow for the next couple of months and years to manage his case. And how you come across at the beginning is very important for compliance with ongoing management. There are a lot of other issues, examining the gonads up front and doing a DRE on the first examination. All of these things tend to make farmers a little on the concern side. So you have to handle that very sensitively, I think, and much more so in male farmers.
I wanted to touch on this just a little bit because, there are, from Sidya's PowerPoint, there seem to be a lot of conditions that may cause, hypogonadism or low testosterone, I guess. I understand that, there is a school of thought out there, or at least some people think that, andropause or, normal decline in testosterone as men age and things like that. And I understand that that's quite controversial. And that the other school of thought is that it's a pathology, that it's pathological. There's a reason why a male might have low testosterone. So do you have any thoughts on that? I don't want to touch too much on it, but maybe just a little bit for registrars out there to kind of,
Well, no, I think primarily it's not to miss a bunch of those conditions. You had sort of associations and pathology. So as Scott said, hemochromatosis is not at all uncommon, and that causes hypogonadotrophic hypogonadism by infiltration of the pituitary with iron. But another patient I've seen recently was also from the bush out west, fair way more out west, with a craniopharyngioma. All right? So it can be anything from the hypothalamus down to the pituitary, and there's a number of conditions that do that, prolactinoma being the most common. But it can be a null tumour and other tumours, for example, in Cushing's syndrome. So if you have a basophil adenoma with hypersecretion of ACTH, get Cushing's syndrome, get secondary hypogonadotrophic hypogonadism. The effects in that area, there's hormone effects and mass effects. And I don't think we got the size of this gentleman's tumour.
It was the size of a golf ball.
Sorry, size of a golf ball.
Yeah.
Yeah.
Did he have visual effects as well?
No visual effects at all. No. So his was, they've just got its height from the cellar floor is approximately 1.69 centimeters. But they haven't actually measured the thing properly.
Right. And he would have had an MRI scan subsequently.
Not from me, but possibly through you, which I haven't got the results of.
Yeah. So, am I allowed to ask the audience questions?
Sure.
Yeah.
Let's put them on the spot.
So, yeah, what else would be Dr. Evans on the back there?
We really are putting you on the spot.
Well, I know he's in some surgery, so... What sort of mass effects would you be wondering about and looking for in a patient who's got a mass the size of a golf ball?
Well, in the cellar turcica or anywhere in the brain.
Yeah, no, sorry, with a pituitary
With
tumour.
the pituitary.
Yeah.
So, well, there's the effects on the surrounding structures. So we've already talked about the bitemporal hemianopia, or the visual changes that you might get. There is the mass effects in general. So if you have an increased space an increased mass in a confined space, then you're going to raise an increase in intracranial pressure. So you're thinking of kind of headaches. You're thinking of going to have to get some help or more on that.
Yeah, that's right. But you have to actually go into the third ventricle to compress the third ventricle, then you get the raised intracranial pressure, generally speaking.
Okay.
But there's some other, I mean, this is tiger country. So on each side, yes, sir.
The small cranial nerves go through the cavernous sinus, and they would be the things you'd look for. I don't know the distinctive nerves that run through, but you'd think that he'd have symptomology that would reflect that, because it's a small space,
Yeah.
the cellar turcica, and to have a golf ball size mass, it probably wouldn't fit, so it'd have to push out. And then you've got the internal carotids coming up and around as well, so you'd have other things going on.
Yeah, well, the prolactinomas actually invade rather than just simply being a mass effect, you also get invasion into the cavernous sinus very commonly in the third and fourth nerve. So be looking very carefully at his eye movements. The visual fields need to be plotted, with proper visual fields. And there's another very good bedside test that one can do. Did you measure his colour vision?
No, I didn't.
Okay. Well, it's another use for the Ishihara chart, because these patients will often describe. I'll give you an anecdotal case. A gentleman who worked in Myers for many, many years and was giving men shirts and matching shirts with suits and the rest. And it really went off badly. Was giving people very bad colours. And it turned out that he just gradually lost his colour vision, and he was no longer able to do it. Had a macro prolactinoma. And this presented, like at 60 years of age.
Wow.
And gradual onset of hypogonadism, particularly in an older man. It sort of figured, the partner is getting on a bit as well, and so that becomes a non-event. But so something that needs to be asked, in people about whether they have that symptom.
I wanted to touch on a little bit too, just for the registrars watching, for the kind of the criteria for diagnosis. I understand what we've talked tonight. I think one thing that's become really clear is that it's really complex and can be very complex, and often may be associated with multiple comorbidities and all sorts of different things. But just for for the basic kind of Medicare criteria or for diagnosis of androgen deficiency, is there a particular sort of way that we go about testing for androgen?
Do you want me to answer that, or Scott?
I'm not aware that there's a significant restriction. If you have reasonable clinical suspicion, and I would have thought the circumstances of this fellow's presentation, particularly if there was an examination and an evidence of small testicular size, then that would fulfil Medicare requirements. I think as a screening test, it would be an unacceptable thing. I think you've really got to, if you're audited, I think you'd have to have the evidence that you had done an examination and had some clinical manifestations that were consistent with this syndrome.
Sidya, is there a kind of a testosterone test which is more accurate, or something like that time of day, or is there a particular way that we would order that test?
I believe the early morning testosterone are more accurate, but not that I did it particularly.
Okay.
They're highest in the early morning, and it really depends on this is clear-cut endocrinology with very high prolactin and clear-cut very hypergonadal. So the gonadotrophins were undetectable, and the testosterone was way too low for a young male. So that's easy. The difficulty becomes with people who've got much more minor degrees. Now, for example, if you had a microprolactinoma with just a modest elevation of the prolactin, there may have been just subtle reduction in the gonadotrophins and the testosterone, and it could be missed. And with other functional types of hypogonadism, and some of it we don't know the cause. There's a hypothalamic problem that's not recognised. It can be attributed to obesity, for example. But when half the population's obese, that's difficult.
Well, and this is a problem. There are a large proportion of rural agricultural workers are obese, and they're also getting older. The average age of farmers is in the mid-50s. I think the really difficult cases in rural presentations is where you get an obese farmer who's clearly saying that he's getting a bit tired, he probably doesn't have any lead in his pencil anymore, and you do a testosterone level and it's low normal or marginally low. And it's very tempting, I think, in those cases to give some testosterone because they'll feel better. Life will be better. But are you actually doing the right thing, I think, is a very difficult question. And once you start, it's very hard to stop.
And I wonder too if we could just touch on a little bit there on just types of androgen replacement, I guess too. Some of them are probably going to be easier to take than others, or more acceptable, or whatever. Do you want to comment on that a little bit? The different kind of preparations and especially in rural areas, what may be the easiest and the easiest for registrars to follow up on as well. Whether you've got any preferences.
Okay. Well, first of all, diagnose it.
Yes.
Conclusively. And there is a big grey zone. And of course, there's this whole area of andropause. The testosterone levels go down with ageing, and it's a question of what is acceptable and what's not. So I have older males who have reasonable testosterone levels for their age. They may have found a younger wife, for example, and they think they're not high enough. So there's a big grey zone about who should be treated. There are criteria. You need to have established pituitary disease or testicular disease. And that's why it's really important to measure the first thing is to measure the gonadotrophins. If they're elevated, then it clearly is testicular. And that's a very easy diagnosis to make. The hypogonadotrophic form is more difficult because there are a lot of causes, including depression and obesity, and there's a lot of grey zone. But once the LH is elevated and the testosterone can just be low normal or borderline, then that is hypogonadism. So that's why I think it's the point I said at the beginning, that you wouldn't really do a thyroid hormone level without doing a TSH. And having accurate TSHs these days, provided that it's primary thyroid disease, have really changed the field. When I started, we didn't have accurate TSH, and so it was much more difficult. But now the TSH goes up, so you can tell that there's primary thyroid problem, or if you can also tell when it's low, which you couldn't do before. And exactly the same with the gonadotrophins. So yes, establish the diagnosis, because I get a lot of people who have been put on testosterone at some stage. Once you've been on testosterone for a while, it's very hard to diagnose what's going on. And it gets very complicated because it's abused in sport, it's abused in the gym culture. I recently, and even in veteran sport, for example, I've had patients who are seeking testosterone and have been started previously on it, and that's very hard to diagnose the condition.
And you see it in physical industries as well, where there's marginal profits and they're high physical, like in shearing and so forth. And
yes. And then, so the first thing is hands up people who think that oral testosterone is effective.
Does that mean you don't think it's effective?
They all got it right. Okay, so yeah, it's hardly ever.
It's what you define effective as.
Well,
That's where Arnold Schwarzenegger and all the professional bodybuilders would say it's effective.
well, in industrial doses, yeah. And but generally speaking, the rule of thumb would be if you diagnose hypogonadism that deserves treatment, then generally you have to use some form of non-oral form of testosterone. And so it needs to be given parenterally. The classic is the horse needle. That was once a month, it is now once every 3 months. It's painful. And there's another problem in that none of them have a flat profile. So after the injection, the testosterone levels go up. So we sometimes get excessive testosterone levels with sometimes more aggressive behaviour, both physical and sexual. And then it drops off, whether it's the 3-month one or the 1-month one. Once it drops off, what happens? They get sweats, they get mood changes, and all the rest of it. So another alternative is to use a subcutaneous implant. It's very effective therapy, lasts for about 6 months, but again, it varies. On the individual, you get some peak and you get some tailing off. They can be at 4 months or longer. The implants need to be given with a trocar, and for a male, they're moderate sized pellets, 200 milligrams. Generally, the dose is 3 of those given, and they have to be given in a separate track. So you've basically got to put in, and they have to be very deep subcutaneous and many centimetres away from the site of entry. Otherwise, they're extruded. So basically, you have to make 3 large tracks in the subcutaneous fat. And for years, I actually ran a clinic almost once a week where we did that in many males because they found it the most effective therapy. So it'd be a one-off for every 6 months. Now we have this, what I think is wonderful stuff, the gel. The advantage of the gel is that it's a daily dose, so we don't get this periodical effect with the testosterone levels being too high and too low. And it doesn't need a procedure in your clinic, and it doesn't need a horse needle. So with the exception of there does seem to be some individuals who put on a normal dose and you measure the testosterone levels and they really don't go up. And I think it's just got to do with skin type. I don't know the answer to that. some people are not educated on properly how to use it. So you can't put on the gel and then have a shower and wash it off, or put on the gel and put on your clothes, because then all you do is transfer the testosterone onto the clothes. So they need to be dry, put on the testo gel and let it dry off completely before putting any clothes on. But to my mind, it's made life a lot easier and it's very effective in getting a steady state testosterone level. Most only need the 1 sachet a day, but there are individuals who need 1.5 or 2 sachets a day.
And that's covered on the PPS?
Oh yeah. Provided.
It's an authority prescription, I believe, though. And
well, yeah, all testosterone is because of the potential for abuse, and there is quite a black market in it. So it is authority, and you have to define whether they have a testicular problem or a pituitary problem. So you need evidence of that.
after you're on the phone for 10 minutes on hold. But they do ask in the authority about the evidence as to why this person is on the Testagel.
So for the ageing male, it's a bit more complicated. And I actually honestly can't remember the exact criteria, but you need elevation of the LH, so indicating that you've got testicular insufficiency, or a testosterone level that is, obviously low. I can't remember the number. I don't.
Below 8.
Less than 8.
Yeah.
2 readings.
Okay.
Yeah. I mean, I really don't deal much in that area, but it is a very much an emerging area. There are a number of studies underway at the moment looking at long-term outcomes. And we'll wait and see whether, all ageing males should be on testosterone or not.
I'd like to pick up on that actually, Jeff, but I'll just go to the audience. We've got a question down here.
Good evening. I'm Dulana. I'm one of the GP registrars in Toowoomba. I haven't had experience, but one of my supervisors have sort of discussed a case with me. So what I'm not sure is, like, once you sort of find a person to prescribe him of testosterone, does he need to be referred to a specialist to get the authority prescription? And then after that, how often would you sort of, is it a review the patient?
No, you don't need to be sent to a specialist to get it, but you do need to get it on an authority over the phone or written authority, and you need to have evidence that you've got the diagnosis right. There are a number of long-term adverse effects of testosterone, and we haven't really talked about those.
I'd like to pick up on that. I mean, especially, I guess, a lot of people are concerned about testosterone and prostate cancer and those sorts of things. I mean, I guess, Scott, out at Clifton, the major demographics would be elderly men who present with this, who may already have an underlying, enlarged prostate or a PSA reading that came back at, 5 or 6 a year or two ago and is being monitored or whatever. Is there considerations there?
Yeah, look, my usual practice is to monitor their PSA when they're older men, and certainly once you get over 50 or so, particularly if you want it. But we have a number of patients at Clifton who are on Testagel who are what you would classify as middle-aged. And I think there's a real risk with the duration of time that they're likely to be on this, because once you start, it's not as if you're going to get...
Is your diagnosis of middle age changing, Scott?
No. I did just think twice about whether or not somebody over 50 would be considered older. But, I think under those circumstances, you've really got to be monitoring these people. And my usual practice is to trend the PSA and to be asking about whether or not they're having urinary symptoms that would be consistent with blockage.
Yeah. I've certainly seen a number of people over the years who've developed prostate cancer on testosterone therapy, as males do. And in theory, if you just maintain an appropriate level of testosterone for the male, at the ageing male, so in other words, not overdo it, then the risk shouldn't be increased. But it is increased compared to being hypogonadal. And so that's the sort of personal choice that the patient needs to make, because most of the time, unless we're treating osteoporosis, then we're really treating symptoms, and treating those symptoms can have some adverse effects, and probably overall results in a shorter lifespan, which is why, one of the reasons that males don't live as long as females, because of the bad effect of testosterone. So you certainly need to monitor it in people who are at risk of carcinoma of the prostate. The great thing is they truly have hypogonadism, particularly due to a previous, say, macropituitary adenoma or severe testicular disease. When you withdraw the therapy, you get androgen deprivation, and many patients have dropped their PSA to undetectable, never to be seen again. So it's actually very effective treatment for some forms of prostate carcinoma. There are other side effects that need to be considered. And have you thought about those? Anybody?
No?
Okay. Well,
I'm going for the
with
short
all these
but
bright people here?
I was going for the short but happy option.
Yes. Yes. And that's certainly if when patients ask me about the risk of prostate cancer, then I do say, well, if we do put you on this, then it will increase the risk. You have to make a decision. And personally, it wouldn't be it'd be a no-brainer for me if there was true hypogonadism. Okay, well, the answer is hypertension. You need to keep an eye on the blood pressure. And polycythemia. Okay, so you need to keep an eye on the hemoglobin. And that's one of the reasons why males who have higher hematocrits than females. And so you can get pathological polycythemia and sluggish circulation. And also dyslipidemia, particularly a mixed, dyslipidemia with elevated triglycerides and low HDL cholesterol.
And yearly DREs and PSAs?
DREs,
Yeah,
what's that?
rectal
Okay. I would call it a rectal examination.
Sorry,
yes.
rectal examination, yeah.
Yes, I would send the patient to their GP for the...
So we can't refer for the yearly DRE then? No?
Not to me, no.
Not to you, okay. All right, we have a question from down in the audience. Lucy.
Thank you very much. Yeah, I'm Lucy. I'm one of the GP registrars. Look, I'm always interested in when patients come in and what they've been doing or who they've been going to before they've come to see you to, look at this problem like natural therapies and that kind of thing. I just wondered if anyone on the panel can comment at all with regard to androgen deficiency. And you often see advertised clinics, offering, nasal sprays or pills to fix their androgen deficiency and what you have experienced and what your opinions are of those, because they're out there and I'm sure, there's a lot of patients that are, going to those clinics or looking into that.
Well, I can certainly say that they haven't opened up a clinic in Clifton yet, and I don't envisage it in the immediate future. However, having said that, complementary medicine is practiced more commonly in the rural sector of Australia than it is in the metropolitan, despite what people would think about the touchy-feely nature of metrosexuals. And so it's not uncommon at all to see people having attempted natural therapy for a lot of things and herbal medicine. So I think you need to take that into account. You have to take a history as to what they're doing, as to whether or not it has any effect on not just the primary condition, but whether it's going to have a secondary effect on the way you manage them. And sometimes if they're really rusted onto their natural therapist or their herbalist in the country, you have to be working with that person so that you know what each other are doing. And it can be really problematic if they're launching off on a tangent of treating one way and you're launching in another way. And so I think you have to work in tandem in that way. But it's a really good question, though, and it's often not considered in primary care.
Do you know anything specifically, Lucy? Like, do you know of any?
I was actually wondering whether testosterone, is actually available in a nasal spray, because you sometimes see that advertised. And I know you've mentioned the gel has been a new breakthrough. Or
Jeff and I wouldn't know about the nasal spray for that sort of a problem. So
Speak for yourself.
Just whether, there's any kind of, natural or herbal kind of testosterone that's being flouted in the same way that phytoestrogens and soy isoflavins and that for female estrogens in menopause.
Yeah.
Is there an equivocal thing that we should be aware of in men?
Well, one of the things about the dose of testosterone for males in mass is reasonably large. So, for example, 20 micrograms of ethinyl estradiol is highly effective estrogen replacement in a female, but you need much higher doses for a male of testosterone. So I can't imagine you'd actually be able to deliver that via a spray. I don't know. You can deliver it by I think they're called a trounch or a. Yeah. So transbuccal.
Yeah.
But to give you some idea, the equivalent dose for ethinyl estradiol in the pellet is one tiny little pellet as opposed to 3 very large pellets for a male. So the mass of it's much higher, much bigger. But it would certainly work transbuccal or any route that's not oral.
I don't think you should discount the possibility that they're getting something by mail over the internet, or that they're diverting animal hormones for injection. A lot of farmers have access to injectables and to injecting equipment and know how to use it. So I think you do need to consider those possibilities. And if you give the diagnosis that they have a low testosterone, you need to be careful that they don't go and deal with that themselves. And certainly you can get mail order testosterone. My understanding is the Australian Customs watches for that. But if you're a farmer, you've probably got reason to be getting testosterone, at least injectable, potentially.
Yeah. And of course, someone who's been using these agents appear to be hypogonadal when they stop them. You get secondary hypogonadism.
Which is why you need to take the history of what sort of farming he's into. It's also a great way to break the... if you're going to examine their scrotum, it's a wonderful way to break the ice for the few minutes before to be discussing about...
He's a Lucerne farmer, so I did get that.
Very good, well done. I always, my students are pummeled with the to ask about the nature of their farming. It's a wonderful way to gain rapport, particularly if you're going to be then asking them to examine a scrotum. I think you need to have that doctor-patient rapport.
Okay, so we're getting pretty close to running out of time on this case. I wonder, Sidya, we started with you with the case presentation, and thank you, it was an excellent case. Any take-home lessons that you kind of got from this case? I think is this sort of one of the first times that you've kind of come across this sort of presentation, and what sort of lessons you've learnt from it, or is this a fairly,
I have seen previous patients with issues with androgen deficiency, but they've all been previously diagnosed, have already been on supplement, and I was just either renewing the scripts or giving them the injections or things like that. But I guess one of the very good learning point over here as a registrar was that don't just dismiss everything for depression or for just obesity related low testosterone level, and actually think about what else could be wrong. Look at that list of other things that could possibly be wrong and look for them actively, because if you're not going to look, you're not going to find anything really. So that was a good learning point for me. And given that there's such a varied idea of that everybody does things differently, it was just helpful for me to look at the guidelines as well. And funny enough, in the guidelines, actually prolactin is one of the first things you're meant to be doing with your full blood count, kidney, liver functions and thyroid, which I didn't know, and that's the day I probably found out. So I guess prolactin will be on my list next time.
Yeah, well, look, I mean, that's great, and I think there's a lot of great learning that's come out of this case tonight, and I hope that people out there who are streaming online have found this quite a rewarding case. So, but we're out of time, so thank you to Sidya for her excellent case presentation, and thank you to our specialist and expert panel.